working as senior registrar at Sheikh Zayed Hospital, Lahore. I welcome my distinguished guests, senior faculty members, and dear colleagues in this August gathering. I do realize that it is very difficult to maintain concentration after the bombardment of lectures since morning 8 a.m. But from my side, I promise that I will not bother you more than 35 to 40 minutes. A very important topic, acute liver failure and emergency, and it will be elaborated very greatly. Directly jumping to my chairpersons, I would like to invite Professor Qazi Masroor. He is ex-professor and head of medicine department and director of medical education, Quaid-e-Azam Medical College, Bahawalpur, and served as in charge hepatitis control program for long period. He owns more than 40 publications in his credit. He's also in faculty of medical education, National Medical University and University of Health Sciences. Sir, take your chair, please. My next chairperson is Professor Sharbat Khan Mandokhil. He's professor and head of department of gastroenterology and hepatology, Bolan Medical University, Quetta. I would like to call upon Dr. Najmul Hassan, sir. He's a gastroenterologist and transplant hepatologist. He's pioneer in LDLT in Pakistan. He started his journey of transplant hepatology from Shifa International, Islamabad, and after a certain period of time, he got linked and developed another transplant center along with his colleagues, Quaid-e-Azam International Hospital, Islamabad, and joined PKLI later on. He also trained dozens of doctors in his transplant hepatology. Sir. My fourth chairperson, she's Professor Lubna Kamani. She's a professor and director GI residency program, National Hospital, Karachi, president Pak GI and Liver Diseases Society, co-chair Women in Hepatology Forum, SASL, publication secretary PSG, member WGO Global Guideline Committee. Now, without wasting further time, I would like to call upon the first speaker, Professor Fayyaz Zuberi, and he will be talking on diagnosis and evaluation of acute liver failure. Professor Badr Fayyaz Zuberi worked as meritorious professor, Dean Medicine and Allied Sciences at Dow University and Health Sciences, Karachi, and consultant physician and gastroenterologist at Dr. K. M. Ruthfo Hospital, Karachi. He also has about 100 publications to his credit. Sir, you also wrote a book titled Statistical Analysis with SPSS for Doctors. Sir, please.
Okay, Assalamu alaikum, and today my topic is the diagnosis and evaluation of acute liver failure. So I'll be going through the definitions in epidemiology and etiological factors and to how to evaluate them. Let's see the definition. Acute liver failure is defined as the severe acute liver injury for fewer than 26 weeks duration with presenting with encephalopathy and impaired synthetic function, showing the INR of 1.5 or higher in a patient without cirrhosis or any pre-existing liver disease. Now, there has been a lot of different data from different parts of the world and with the difference in etiological factors of acute liver failure. From the US Acute Liver Failure Study Group, which was formed in 1998, it showed the ALF data of around 2,614 enrolled from 1998 to 290 and found that most common cause of ALF were acetaminophen, followed by indeterminate causes, idiosyncratic drug reactions, and viral hepatitis A and B. Currently in the United States, spontaneous survival for all etiologies of acute liver failure is approximately 45% without liver transplantation. So carries a very bad and poor prognosis. The outcome of ALF, however, varies by etiology, with some favorable prognosis being found with acetaminophen overdose, hepatitis A, and ischemia, and more poorer prognosis with other drug-induced ALF, hepatitis B, and indeterminate causes. Well, the causes may vary in developed countries, and they may be different in developing countries. The hepatitis A, B, and E are the leading causes of acute liver failure worldwide and are mostly seen in developing countries compared to the drug-induced liver injury, which is more common in developed world. In a recent review of epidemiological of ALF over the past 50 years reveals that the relative incidence of acute liver failure secondary to hepatitis A and B have declined, while that of acetaminophen has increased, mainly in the United States and Western Europe. Now you can see in this chart that the last 15 years data of showing that around whole the world that the paracetamol injury or acetaminophen injury leads the causes. And then you can see the next peak with the indeterminate causes and with some less with hepatitis A and B as compared. I'll skip that. Now, hepatitis A and E are the leading causes of liver failure, most of which were reported from developing countries. From B infection could cause liver failure from both acute infections as well as from reactivation of hepatitis B following initiation of immunosuppressive therapy also. So co-infection with both B and C, although rare, could lead to ALF, and while it is very rarely seen with hepatitis C alone. Other viral etiologies of acute liver failure include herpes simplex virus, cytomegalovirus, EBV virus, parvovirus, adenovirus, and Erisula-Zoster viruses. Coming to the pathophysiology, pardon me. The most causes of ALS, except from acute fatty liver of pregnancy and Rice syndrome, will have massive hepatocyte necrosis and or apoptosis, leading to liver failure. Hepatocyte necrosis occurs due to ATP depletion and causing cellular swelling and cell membrane damage. It just goes on inside. The pathophysiology of cerebral edema and hepatic encephalopathy is seen in ALF is a multifactorial and includes altered blood-brain barrier secondary to the inflammatory mediators leading to the microglial activation, accumulation of glutamine secondary to ammonia crossing the blood-brain barrier, and subsequent oxidative stress leading to depleting of ATPs and GTPs. This ultimately leads to astrocyte swelling and cellular edema, which is one of the very serious consequences of ALF. The initial injury in acute liver failure results in death of hepatocyte, leading to systemic inflammatory response and multi-organ dysfunction. This is another mechanism which goes on side by side with the ALF and leads to the mortality. Significant neurological, cardiopulmonary, and renal sequelae are associated with acute liver failure, leading to cerebral edema, intracranial hypertension being the most serious of these complications. And these complications lead to higher mortality also in this patient. Acute renal failure complicates around 30 to 50% of the patient and can be a sign of poor prognosis, although mortality is mostly related to neurological dysfunction and infections. So, while dealing with these patients, a comprehensive history helps to delineate the possible etiologies Any history of hepatic disease and hepatic decompensation has to be taken. Any concomitant relevant chronic health conditions should be noted. The timeline of symptoms with which the patient presenting, especially with paracetamol poisoning, should be noted. Toxic habits or high risk behavior, and any herbal drugs intake, because people don't take it seriously and mark them uh, that they are non-harmful, although they are in herbal products are very harmful and have shown quite a cause of liver failure in patients. A family history of liver disorders like Wilson disease or thrombotic disorders like Budd-Chiari syndrome should be taken, and any recent surgery where we can implicate the anesthetics complication of acute liver failure should also be taken note of. Now, physical examination in such cases should include hypotension, checking for hypotension, mental status, fever or infections which can be co-concomitant with this disorder, upper quadrant right-sided pain and tenderness, nausea, vomiting, and any fluid overload assessment should be done at the initial workup of the assessment of the patient. After doing this examination, one should seek out the history from where we can see the primary testing, the first tier testing, and then leading to second tier testing in such patients. This is including paracetamol poisoning. We should firstly do the serum paracetamol consultation, and if there is positive, we should go on to second tier precipitation of paracetamol hepatocyte, protein adducts should be done. If ischemia, the blood pressure history and echocardiogram followed by enzyme pattern and rapid leads to rapid recovery. And hepatitis A, IgM, hepatitis A antibodies. For hepatitis B, IgM, hepatitis B core, hepatitis B surface antigen, and HT-HDV should be done, followed by the PCRs of B and D as necessary. In hepatitis E, IgM is suspected IgM anti-HEV followed by HEV PCR. In Delhi, the known case of the drug that was used and a liver biopsy may come in. In autoimmune, ANA, ASMA, and autoimmunes, immunoglobulins followed by liver biopsy. In Wilson disease, slit lamp examination, hemoglobin less than 10, and the alkaline phosphatase bilirubin ratio of less than 4 should be taken, followed by 24-hour urine copper, liver biopsy, and quantitative liver copper. For Budd-Chiari, Doppler's ultrasound of hepatic circulation and hepatic venograms. For pregnancy, reduced HELP syndrome trimester, third trimester pregnancy, preeclampsia, and coagulopathy, and an ultrasound has to be done. For herpes simplex virus, IgM, HSV 1 and 2, and blood HCV, DNA, PSR should be done. For any malignancy, CT MRI followed by a biopsy, targeted biopsy of these lesions has to be done. What's the role of imaging? Abdominal imaging to determine the presence of cirrhosis, features of portal hypertension, hepatocellular carcinoma, etc. can be seen. Abdominal sonogram and Doppler could be easily seen with the renal injuries or vascular thrombosis or Budd-Chiari, and blood-brain imaging and CT and MRI has to be done to organic organ. You see, the brain edema is so severe and should be taken so seriously that even moving for a person for CT in a patient in acute liver failure may cause permanent brain damage in these cases. What's the role of biopsy? Only if clinical interpretation through history examination and laboratory and imaging modalities are inconclusive, a transtubal liver biopsy should be performed to ascertain specific etiologies of ALF such as autoimmune hepatitis, malignant infiltration, lymphomas, herpes simplex viruses. So limited role of one. Now on the base of biopsy, there are 3 categories of liver type injuries that can occur. The first one is extensive microvascular steatosis. This pattern is rare and has been observed with tetracycline and nucleoside analogs such as Zuberi. Second is most common one, and which is the necrosis with marked inflammatory activity, is seen in idiosyncratic drug reactions similar to acute hepatitis pattern discussed earlier, and confluent necrosis involves most of the liver parenchyma. The most commonly implicated drugs are INH, antituberculous, and antimicrobial agent, etc. Any drug that causes hepatitis can potentially cause acute liver failure. And the third one is necrosis with little or no inflammation. This pattern is seen with acetaminophen, recreational drugs such as cocaine and MDMA, acticity, etc., and industrial organic compound like carbon chloride, and some herbal preparation, and necrosis can be accomplished with steatosis also. Now, show you some of the histological features of some of these presentations. Now, panel A shows normal liver at low power, while panel B shows at a high power of 400. A normal hepatic lobular pattern can be seen along with the portal tract, especially could be recognized in panel B. Again, a very high power resolution in panel C, hepatic lobule showing centric hepatic vein. And when you compare this with the panel D, which is due to the INH positive toxicity, a complete parenchymal loss with no hepatocytes remain, and the normal parenchyma has been replaced by ductular reaction. You can see a lot of ductular reaction in these small ducts are appearing all the way in the hepatocytes. The panel E shows heterogeneous areas of necrosis and parenchymal regeneration observed with nitrofuran toxicity, and the same regeneration of these nodules can closely mimic regenerative nodule of cirrhosis as shown in factor A, and they may mimic a regeneration of cirrhosis, although they are not. And panel C shows typical features of paracetamol or acetaminophen toxicity with zone 3 centrilobular necrosis. Many hepatocytes show steatosis and necrotic zone. Lipid drops have co-sealed, and acute liver failure related to hepatitis B is shown in the panel H with prominent plasma cell infiltrate within the portal tract, which is quite a unique feature of fulminant hepatic failure related with hepatitis B. So this disease is not limited to one domain. You can see a lot of problems and system involvement, which should have a very closely knit teamwork between a physician, a gastroenterologist, a radiologist, a histopathologist, especially trained in liver histopathology, an interventionist, and a nephrologist, because 30 to 40% of these patients develop renal failure and needs management of these patients. Thank you for your patient listening.
Thank you very much, sir, for such an elaborated and pertinent talk.